Good morning, everyone. Welcome to TeleShadowing. We're recording the session and live streaming it to YouTube. We'll be having a Q&A session at the end, and you can ask questions in the chat box and they'll be addressed.
Good morning, everyone. Welcome to TeleShadowing. Sorry for our technical difficulties. I'm honored to introduce our mentor for today, Dr. Ahmed. Dr. Ahmed is an assistant professor of pathology and dermatology at Rush University Medical Center in Chicago, Illinois. He did a research fellowship in medical education at Johns Hopkins, his AP-CP residency at Loyola University of Chicago, followed by fellowships in hemopathology at Yale and dermatopathology at the University of Arkansas. He is the founder of monthly hepatopathology Journal Club on Twitter, Clubhouse, and Pathology Outreach Program for high school students. As a great mentor, Dr. Ahmed was most recently named among ASCP 40 under 40 top 6 honoree. Now I'd like to request Dr. Ahmed to start today's session. Thank you.
Thank you, Manal, for the introduction. I'm gonna go ahead and start sharing my screen. So I hope you guys can see my screen. Okay, perfect. I see thumbs up. So the title of my talk today is The Dark Side. Has anybody heard of the song The Dark Side? No, okay. So if you guys get a time, like after this talk, search the song The Dark Side by Alan Walker. And that kind of, every time I listen to that song, that kind of reminds me of pathology. But let's just start. So I don't have any disclosures. And in this, before I talk about pathology, I just want to bring a conceptual idea that whenever we make a decision, our decision is usually based on two things, our knowledge and experience, or in other words, our data and experience. So you can be experienced, a physician, for example, we are talking about medicine, so a physician can be highly experienced, but if he does not have enough data, the decision is going to be skewed, right? So it's not going to be a balanced decision or not an informed decision. So there is an importance of both data and experience while we make a decision. So keep that in mind, and then we're going to move on to the next slide. So in this slide, I'm trying to show like personalized medicine and what benefits it provides, and we do not use personalized benefits, how it is different from personalized medicine. So in personalized approaches without using personalized medicine, you just treat everybody the same way without taking into account patients' own data and patients' own genetics, patients' own labs. So some people would benefit, some people would not, and there would be some adverse effects as well. On the other hand, on the right side, with personalized medicine, if you use biomarkers or diagnostics, that means, in other words, means like patients' data or patients' attributes before using therapy, it would benefit more patients and compared to the approach without personalized medicine. Adverse effects would still be there, but compared to a non-personalized approach, there would be much more and wider benefit to everyone. So that's to highlight the importance of personal attributes or the data points coming from the patients. So just an example of medical situations that you can see. So where does these data points come from? So one is radiology and the other is pathology. So pathology is one of the branches of medicine that produces the largest number of data points in medicine. That produces the largest number of data in terms of lab and also anatomic pathology in terms of tissue biopsies. And then, so what is pathology? I wish I could hear you guys. So I would ask you guys, what do you think? What is pathology? Like, what do we deal with? Anybody want to chime in? Okay, I see some chat. Yep, it is the study of disease. That's correct. Study, cause, and origin. That's true. Okay, let me show you. Does this ring any bells? Have you guys watched this movie? That was a very stereotypical pathology-related movie. The Autopsy of Jane Doe. A medical profession where you deal with studying different types of cells in a lab. Okay, that makes sense. So usually in our society, because of, I guess, like TV shows, pathology is like very much connected to like autopsy or like forensics. And that's considered like the main thing that we deal with in pathology. But in reality, that's actually it's a very small part in terms of subspecialties that are part of pathology. So autopsy or forensics path, that is one of the subspecialties, but that's not the main thing that we do. So here is like a definition that I compiled. So pathologists are medical doctors. So they do go to medical school, and then they specialize in microscopic and molecular diagnosis of disease. So we make the diagnosis, right? We make the objective diagnosis, because a clinician can give you differential diagnosis, or even if they're convinced that based on your symptoms and signs, this is the disease that you might be suffering from, but they cannot give you an objective evidence, right? It's based on their experience, but the data is missing. So to add that data and to add that objective evidence, that's what we do. And how we do that, we take sampling of either body organs through surgical procedures. The surgeon gives us the organs, or we take tissue, cells, and fluids in terms of biopsy. It could be a liquid biopsy in terms of if we do like fine needle aspiration, if it's like a cyst or something, we're gonna poke a needle into it and get some fluid out of it and examine it. Or we can actually, especially if it's like a skin or if it's like a superficial organ, you can just go poke in a needle and get some tissue out of it. So that's a biopsy procedure. Or obviously if it's postmortem, so you have the entire body to examine, and that would constitute the autopsy or forensics. And the new role is in precision medicine, the examination of genetic material. So nowadays, in many diseases, we are not just examining the biopsy or tissues or cells, but we are going a level higher and also examining the DNA and RNA material and see if there are any abnormalities in there. So there is a wide scope of work that we do. So who are the consumers of pathology? So obviously patients, and in this photograph, and they're not only patients, but also doctors. So our consumers are not only patient, but also doctors. We are often called doctor's doctor. So because doctors need us to make an informed decision in terms of treatment and management, because if they don't have objective evidence of diagnosis, then they cannot treat it effectively. And also in terms of legal and insurance purposes, you need that objective evidence. So oftentimes you do need that biopsy or you do need that surgical procedure to get to the diagnosis. This is just the major scope of pathology practice, what kind of patients that benefit from us the most. And that's because these patients undergo repeated biopsies, and they are kind of like frequent flyers for us. Because a transplant patient, they have to be they have to be monitored continuously. So we often get biopsies on those patients repeatedly to make sure that their organs are not rejected by the body and by the body immune system. Similarly, cancer patient, we not only diagnose them, but we also grade them, stage them. So based on grading and staging, you have to treat them more aggressively or more lightly. Transfusion patients, often, so we like type and screen their blood and then match it with them. And similarly, a transplant patient, also we match the organs before the transplant, so all that. And then neural, again, as I mentioned in genetics, it's targeted therapy. So whatever we tell them about whatever the results are of genetic material, the therapy is targeted to that particular genetic abnormality. So this is kind of like a brief scope of pathology practice, but we get biopsies from all these specialties in medicine. So surgical specialties, they probably constitute the major part. They give us the major volume of our work. But besides them, gastroenterology, they scope patient and take biopsies out. ENT, so they go in oral mucosa or like oral or nasal cavity or respiratory area and take biopsies from there. Urology, they go into ureter, kidney, bladder, so they give biopsies from there. OBGYN go into genital areas. Hematology, oncology, they take bone marrow biopsies, blood, lymph node. Dermatology, skin biopsies. Infectious disease give us microbiology that's related to it, and any part of the body can be infected, so that's related to as well. And radiology also help us in getting to the radiology is helps us in getting the sample effectively, because sometimes if it's a deeper organ, we cannot just poke the patient. So radiology provide us with the tools like CT scan or other modalities to help us get to the sample. So we are essentially interacting with every specialty in medicine. So what do we do in pathology? So I'm going to quickly go over workflow. It's just a brief summary, and I'm sure you guys cannot see what's happening in there. So I'm going to go step by step. So first of all, we have these containers. So the specimen comes in these containers. It could be small to big, depending on the size of the specimen. If it's like a whole organ, liver or lungs or heart, it's going to be in the big one, or otherwise it's going to be a small one. And it's, first of all, it's accession. So it's given a unique ID so that throughout the process afterwards, after being accessioned, the specimen is not lost. There is no like quality issues. There are no patient safety issues. So we have to make sure that the container and the specimen is matched to the patient. So that's the very first step in pathology, is accessioning. And there is always a dedicated person who is accessioning these specimens and making sure that they go to the right person, go to the right pathologist. They are connected to the right patient, right physician. So everything is done in a very high quality manner. Anybody knows what's this formula I'm showing you? Anybody from chemistry? Okay, I see a chat box. Carbonyl, aldehyde, ketone, I like it. Yep. So it's actually formaldehyde. So anytime we have specimens, we put formaldehyde in it. Why? Because it kills the specimen essentially. It kills the cell, but it actually does not kill it. It puts it in a static form, because otherwise the cell's going to decay if we just leave them alone, or if you leave them in saline. So formaldehyde puts them in a static condition. It essentially freezes them in whatever condition they are at. So this is like lock them up in that condition so that it does not decay. So that was the first step. So accessioning and then putting formaldehyde. The next step is usually grossing. So what is grossing? What grossing is that we cut the specimen to our choice, like depending on where we want to examine it. Because if it's like a liver, we cannot examine the whole entire liver. We can examine it on gross examination just by looking at it. But under microscope, we cannot examine the entire liver. So we have to go to the point of interest, like wherever there is tumor. So we cut it, slice it, and then see where the tumor is or where the disease process is. And based on our gross naked eye examination, wherever we think is the best suitable area, we take a sample from it. And that's what grossing is called, to get the best sample out of the sample. That's essentially grossing, and that's done by a pathologist or a pathologist assistant. And once the piece is taken out, it is put into these plastic blocks, which has holes in it. And I'm going to tell you why there are holes in it. So you put in there, it's like the thickness has to be like less than a dime. So, and then you put it in that container, and then the tissue goes into for processing. And what processing is, it dehydrates the tissue so that it becomes stiff. And I'll tell you why we need it to be stiff. And that's what the holes were in that blocks, to dehydrate the tissue. Okay, and it takes at least 5 to 6 hours in these processors. And those are done by histotechs or lab histotechnologists. And I'm going to tell you that about them in a bit as well. So the main step in this is just dehydration of the tissue. The next step is once the tissue is dehydrated, we put wax on it. And wax provides a medium for it to, when we are cutting the tissue, it provides the structure to the tissue so that it doesn't falls off. So, and that's how it looks like when it's like embedded in the wax. So we have the tissue, dehydrated tissue, and wax around it. Once that is embedded, we cut like very thin slices. And by very thin, it's 0.5 micron thin slices by microtome. So we mount the block on this microtome and then keep cutting it. And you can see how thin slices, like very thin slices are cut. And then you put these slices on a glass slide. And once they are put on glass slide, then we stain them, because right now if you go back, it looks very black and white. So you can see it's very black and white. So there's like no color. And two colors that we use are pink and purple. And and nowadays we have automatic stainers. So you can see on the right-hand side picture that all the slides are put together in a block, and then they're dipped into different solutions and different stainers. So two colors that we use are hematoxylin and eosin, and both are compounds with chemical formula. One is basic, one is acidic. So the basic one is colors blue or black, while the acidic ones is more pinkish. And because our nucleus in the cell is acidic, it has DNA and RNA, so it's like more acidic. So it takes the basic dye and it turns more blue or more purple. So more intense color is of the nucleus. And cytoplasm, being more basic, have all the other components in the cytoplasm. It takes the acidic dye and turns more pink or purple. So when we are looking in the microscope, we know what is cytoplasm and what is nucleus based on the color of those stains. And that's how like ultimately prepared slides look like. So you can see the shades of purple and pink on these slides, and different levels. We cut through different shapes, different sizes. So all based on grossing, when we are grossing, how big or how small of a piece we took. And all of that depends on that. And then the color intensity of staining also depends on like what we are seeing, if it's like more nuclear material or more cytoplasmic material. And then we have a microscope, and pathologists then examine these slides. Any questions so far? Okay. So that was like the routine procedure for making a slide or workflow, or when we are not in a rush to give us the result. But sometimes there are emergencies, or there are like surgical procedures that want answers right away. So they don't have time for processing, for tissue processing, that hours of like dehydration and embedding and all that stuff. They say, like, give us the answer right now. So we have like 20 minutes essentially to give them the answer. So anybody knows what I'm showing you here? Okay, I see chat. Nitrogen, dry ice, exactly. Yep, this is liquid nitrogen. So we use liquid nitrogen to freeze the tissue right away. So when we get those urgent procedures or urgent, the clinician want results like right away, especially during surgeries. So we freeze the tissue, and that's how it looks. So this is all just ice. So that ice provides that medium for it to be cut through, because we are not dehydrating the tissue, we are not embedding it and all that stuff. So we have these cryostats that has like minus 23 degree temperature, and we just freeze the tissue in there, mounted on these cryotome on these cutting devices, and then we just cut the thin slices out of it. And this is, instead of wax, we have this ice, and there is a tissue right in there as well that comes out of it. So that's called a frozen section, intraoperative usually. So oftentimes surgeons wants to know if they took enough tissue out, or for example, if patient has diagnosis of cancer, so they're taking the organs out, and they want to make sure that they're not leaving any more tumor in the body. So they give us the margins of the specimen. So make sure that they took it all out. And if we see there is still cancer, we tell them go back and take more tissue out. And if there's no, we tell them, okay, it's fine. You don't need to, you can end your surgery. So that's another aspect of pathology practice that we do. So what are career paths that you can take in pathology? So first I'm going to talk about MD route, and then I'm going to talk about non-MD career options in pathology. So obviously for MD route, you have to go to college for 4 years, then medical school, that's also 4 years. Pathology residency is generally 4 years. There are a few schools, a few programs that offer 3 years. And because pathology residency is combined anatomic and clinical pathology, and I'm going to show you like there are different just subspecialties and different areas of pathology that they deal with. So most of the programs are combined anatomic and clinical path. And when you go out in job market, people prefer anatomic, both combined AP and CP residency. But there are options if you know that you want to just practice AP, so you can do only 3 years of residency. There are not as many programs for only 3 years residency out of 143 programs in total, but that's an option. And after that 3 to 4 years of residency, you do have to do a fellowship. That's generally 1 year. Some programs have 2 years of fellowship that includes a research year, but that is kind of mandatory. Nobody says that it's mandatory, but it is. When you go out for job market, everybody wants you to have a fellowship. So you essentially, it's like 5 years of training after medical school to be a pathologist, specialty trained pathologist. So now let me explain like what is anatomic and what is clinical pathology. So anatomic pathology mainly deals with tissues, organs, like whenever you get a biopsy, either liquid or a solid biopsy, while clinical pathology is mostly like lab tests. So for example, if you've seen like phlebotomists taking blood samples, so anything that's related to microbiology, infectious pathology, chemistry tests, that's, for example, like measuring your sodium or potassium or like calcium, all those goes to clinical path. And similarly, transfusion medicine related to like your screen type, you're screening your blood type, what's your blood type, all that goes to transfusion medicine. Hematology is kind of divided between AP and CP. So you do get blood and bone marrow samples and lymph nodes to anatomic pathology, and then you get peripheral blood smears or blood samples to clinical path. So you have to combine them and analyze them together. Molecular path can also be done on both liquid and solid biopsy, so it's kind of combined. Clinical informatics is a new specialty, and that deals with transfer of data and like organization of pathology data, because as I mentioned, it's the branch of medicine that produces the largest amount of data in medicine. So it has to be managed in some way, an organized way. So that's what clinical informatics do. And then a new field is in vivo microscopy, It's a very not like a very nascent branch, and this is still in like research stage. But what you can do is you can insert a scope, for example, in your esophagus, and then that scope takes images, big 3D images, and that's what you analyze. So it's kind of in vivo microscopy. You don't have to take the sample out. So, but that's still something very new and not widespread, used widespreadly. Work hours are typically 40 hours on average. I mean, I said an average. You can go up to 60, 70 hours depending on where you are working and what's the volume in your hospital or your practice setting. So that all depends on that. But essentially, compared to other subspecialties, is definitely less. The salary range is about, that's like the median salary. I would say the starting is usually not that much. But compared to other subspecialties, pathology comes somewhere in the middle. And that was also just a survey from Medscape and about the satisfaction of pathologists with their field. And they usually survey every year and see what specialties are most satisfied with their profession. And pathology comes at about 85%. So that is pretty good. So now I'm going to talk about non-MD careers in pathology and laboratory medicine. So we have different organizations that accredit those occupations that are non-MD. So we have National Accrediting Agency for Clinical Lab Sciences, the American Society for Clinical Lab Sciences, and then Commission on Accreditation of Allied Health Education Programs and American Society of Cytopathology. And there's also American Society of Clinical Pathology that I did not mention. So those four organizations are big four organizations that accredit non-MD professions in pathology. So first I'm going to talk about pathologist assistant. What do they do? So remember I talked about grossing. So that's done by either pathology residents or pathology assistants. So pathologist assistants, so they oversee all aspects of grossing process. They perform gross tissue examination and oversee daily operation in the frozen section lab and autopsy service. They can essentially have managerial positions in the lab. And they also take photographs of the surgical specimen. To become a pathologist assistant, you have to, it's usually a 2-year program after college. There's also a master's degree option. Science GPA 3 or higher to get admission. Salary range, that's about $67,000 to $112,000 a year. Work hours, 40 to 45 hours a week. 11 programs in total, accredited by naacls.org. So if you go to that website, you can see all the programs that train pathologist assistant. Moving on to histotechnologists. So they usually process the tissue or embed the tissue, cut the tissue. So all those are stained, including frozen section. And then there are also immunohistochemical and special staining labs. Those are just different labs in and under pathology lab that are done by histotechnologists. So this one also requires a bachelor's degree and usually a 1-year program. Most of the programs I know are 1 year. That gives you an associate degree. 35 programs nationwide, 47,000 to 62,000 hours a year. Work hours are 40 hours. But I do have to tell you, some of these subspecialty of histotechs are paid a little more than what's given here. For example, derm path, people working in dermatopathology labs, because it requires more precise embedding skill. So they pay you a little more than average histotechnologist. And then we have a cytotechnologist. So as this name mentions, they are examining the cells instead of tissues. So usually dealing with the liquid biopsies. So study of cell, examine cells of the cytoplasm and nucleus of the cell to determine pathological condition. And it receives the specimen, prepares it, and makes and also they examine the slides, these cytotechnologists. So they pre-examine or they preview the slides before the pathologist and mark the points where they think are the areas of interest. So the pathologist have just go directly to those areas. This also requires bachelor's degree and an accredited cytotechnology training program. Length is about 1 year, 22 programs that are accredited, salary range and hours, again, 40 hours a week. And then we have medical laboratory scientists or technicians. So they usually work in clinical chemistry. So they're working used mostly in this clinical pathology labs and not anatomic pathology labs. So the three professions that I just told you, histotechs, cytotechs, and pathology assistant, they are working in anatomic pathology. And then medical laboratory scientists or medical laboratory technicians, they usually work in clinical laboratories. So they're dealing with clinical chemistry, hematology, immunology, immunohematology, microbiology, and molecular biology labs. They perform lab procedures, so evaluate, interpret the results, integrate data, problem solve, consult, conduct research, and develop new test methods. So in clinical path labs, most of the work is done by MLS or MLTs, right? So medical lab scientists or medical lab technicians. So pathologists only supervise them in the clinical path labs. The actual work is done by medical laboratory techs. This is the pay scale. MLT, it's 2 years associate, while MLS is 4 to 5 years bachelor. And these are the number of programs that prepare MLT and MLS. I want also touch base on scholarships that are available, especially the STEM student scholarship that people in high school that are interested in medical sciences degrees. So ASCP, American Society of Clinical Path, they do have this program that help STEM students. And then also ASCP Foundation Laboratory Student Scholarship. That's obviously for those who are applying for or who are already in these lab professions, non-MD lab professions. So these are just a few scholarships. So future directions, where are we going and what we'll be doing? So this was just an example. So I often go to the high schools, and I put that picture up there and ask the students, what do you think? What does this picture brings you in mind? So I always talk about these designer babies. So, and I don't think we are far from that. So CRISPR or CAR T cells are two of the genetic modulation strategies that are used in pathology that can edit our DNA to remove diseases or whatever purpose it can be used for. But these are the two technologies essentially that are already being used. CRISPR is not as much widely used, but CAR T cells are actually used in hematology, hematologic conditions. So many of the leukemias and lymphomas, you can use CAR T cells to kill the tumor cells. So what are CAR T cells? So CAR T cells are T cells. We take normal T cells out of our body and then edit the DNA of those T cells and then put them back into the body to fight the tumor cells. So they are just more powered immune cells from our own body. So those are CAR T cells. So pathologists play a role in that. And then bioinformatics. So as I mentioned, there's so much data and it needs to be organized. It needs to be provided and be able to analyze when the time arises. So bioinformatics deals with that. There is actually a 1-year fellowship in that field as well. And then we have digital pathology. So everybody is recognizing the need for like communication and like efficiency and productivity. So everybody's thinking like, why not just get rid of these glass slides and just like scan them on the computer? So you can, instead of examining it under the microscope, you can just see it on the screen. And many practices have actually already transformed their practice into digital pathology. So that's also new. It's the main issue is the cost and the labor. Somebody has to scan it, and then scanners are expensive by themselves. So those are a little bit expensive, but that's where the field is going right now. And that also allows us to like examine a specimen, examine slides from like different parts of the world. So you can have consult service sitting at your home from all over the world. And then on the same lines, using digital pathology, the deep learning and artificial intelligence. So instead of we instead of a pathologist like examining the slides, we are training artificial intelligence systems to to identify the cells, identify abnormal cells, or identify like different mitoses. Why mitosis is because oftentimes when the mitosis, if you see mitosis in tumor, that means it's proliferating, so it's bad. So instead of looking for mitosis in a big slide, big tissue chunk, have artificial intelligence help us in making diagnosis. So that's also another thing that's being explored, and kind of research is coming out in that specialty as well. These are these subspecialty societies in pathology. So in terms of policy and advocacy, pathology is strong. First three organizations are national. These are like national big pathology organization having more than 7,000 members in the country. College of American Pathologists is a nationally recognized CAP that when you're board certified in pathology, you become the fellow of the college. They have a strong advocacy and lobbying role, and the Washington, D.C. as well. So in terms of, they support us and advocate for pathologists in terms of like payments and like Medicare, Medicaid, and all those issues. American Society of Clinical Path also is on the same line, but also deals with non-MD careers and mostly accredited those non-MD career professions. United States and Canadian Academy of Pathology is like highly academic research organization. So whenever residents or trainees are doing new research, they submit their abstracts to them, and then there's an annual meeting where all those scientific researches are presented. And then we have the subspecialty societies: cytopathology, DermPath, National Association of Medical Examiners, so anybody interested in forensics, that's their organization, molecular pathology, hematopathology, and clinical chemistry. So in terms of their national presence, pathology is quite strong. So that was kind of brief overview of pathology. And then I'm gonna just quickly show you the examples by case studies, how much work we do and what role we play in patient care. So this was a 65-year-old patient with history of heart transplant who presented with shortness of breath and weight gain, and then a biopsy of transplanted heart was performed. So as I mentioned earlier, it's very pink and purple slide. So this is what slides look like. The tissue on the slide looks like. So pink is mostly cytoplasm. So those are actually, that pink is a skeletal muscle, and blue is the nucleus. So you can see a lot more nucleus in between these pink areas. So let me tell you, these pink areas are actually heart muscle. So these striated pink muscles, these long filamented like structures, those are heart muscle. And those blue things are actually our immune cells or lymphocytes that are kind of attacking those heart muscles. And that's what this biopsy was meant to show, because the patient was presenting with shortness of breath and weight gain. So the body was reacting against this transplanted heart. And that was proven by these, we can see these immune cells attacking these heart cells. And this heart cell is almost eaten up by these immune cells. And these red is just hemorrhage or the red blood cells in there. So based on these findings, usually you should not see any of these immune cells in heart tissue. It should be just pink, mostly pink, and no blue in there. So the diagnosis was made of acute rejection, and patient was put on steroids to calm down the immune cells. So just to show you the importance of that biopsy in terms of treatment. Next case is a 26-year-old female who presented with perirectal and conjunctival hemorrhage. Complete blood count showed increased white blood cells, and a peripheral blood smear was performed. So it's a young patient who's presented with hemorrhage, and usually peripheral blood smear is like one of the initial lab investigations that's done like almost every patient. And what is peripheral blood smear? You take a drop of blood, put it on a glass slide, and just smear it out, and that when you smear it out, that's what you see. So these are our red cells, and that's what you should see most of the time. And these tiny ones are our platelets. And these large ones are abnormal cells. So these are actually white cells, but abnormal white cells. And I'm going to show you what normal looks like in a minute. So based on the morphology, you can see these are bilobe nucleus, kind of looks like butterfly nucleus. So this is the cytoplasm, and this is the nucleus. So we said it is a type of leukemia, that is acute promyelocytic leukemia. So these are essentially just immature white blood cells. They're not maturing. And this is the designation of this leukemia. And as soon as the clinician gets this diagnosis, they start them on a drug called Atra that affects these cells to become mature. Because if they don't mature, they're going to clog the arteries and the patient is going to die of hemorrhage. So that's an urgent diagnosis. You have to make this diagnosis right away. And for comparison, this is our normal blood smear. So we have red blood cells, we have those tiny platelets. Oops, sorry. We have tiny platelets in the background, and then we have these normal white blood cells. So you can see these normal white blood cells have multiple lobes in the nucleus. So these are mature neutrophils that are normally seen in our peripheral blood. But those ones were bilobe, big nucleus. So those were abnormal, immature cells. So this was an example of a normal smear. And then I think this is third of the fourth case. So clinically, you might think they both look similar, right? These brown patches you often see on older individuals and Caucasian patients, and they kind of look similar, right? On a clinical exam, but so one is benign. So one just happens due to sun exposure. So you can see more pigmentation. So it's just pigmentation that's causing this clinical image, right? But this is benign. But the other one is also increased pigmentation, but there are also these abnormal cells. So those are melanocytes. So these are melanoma cells. So clinically, they can look very similar. So you do need that biopsy to differentiate between benign lesion and a malignant lesion. So this melanoma can be deadly if not treated right away, while that benign lesion, you can just leave it alone. Similarly, the last case, they kind of look like a scabby lesion. They are kind of like they're erythematous. They're kind of looking angry, a little red and tender. But they both look similar, right? And when you examine it under the microscope, so this is the one, it kind of looks abnormal. So this is your normal skin on this edge. So this is your epidermis, and then you have your dermis. And this is what normal skin should look like. But this looks like this normal, your epidermis is growing inwards. So that's actually a cancer. On the other hand, this other lesion, this kind of looks same. This your normal epidermis kind of growing deep. But when you go higher power, you actually see these organisms that causing this epidermis to grow inward. So this was an infection. So both entities are treated differently. They look similar on clinical exam, but for this, you have to treat them with antifungals. On the other hand, the first one, you have to treat it with surgery. So based on what pathology tells, you will have to treat them differently. Just a quick overview of this is a magazine, the Pathologist magazine, that gives a lot of if there is swelling, is it automatically assumed as some kind of infection? Not necessarily. No. It could be anything. I don't know if you guys could hear it. So I don't know if you guys saw proteomics, but that's another field, another new field that's being investigated right now. So instead of analyzing DNA and RNA, now we are analyzing the proteins that are formed by DNA and RNA to see what disease process is happening in the body. So that's a new field called proteomics. So take-home message that brings me towards the end of my presentation. Pathology is critical to patient care. It provides objective evidence of disease and therapy, because oftentimes, even after therapy, they give us samples to make sure that there is no disease left in there. So if there is, we tell them they need to treat it more or treat it differently. There are multiple career paths. There's increased job satisfaction. And at the end of the day, even if you don't go into pathology, it's important to be a well-informed physician, because oftentimes we get calls from like surgeons or from other physicians that tell us like, we need the results like right away. And because they don't know what's happening in that black box of pathology. So if you know what's happening, what's the workflow of pathology, you would not ask those unrealistic questions. So whatever subspecialty you go into, be a well-informed physician. Communication is the key. If you think you're communicating enough, you are communicating barely enough. So always remember that in mind, especially in medicine. Final thoughts in life in general, I would say find a purpose, seek mentors, seek mentees, I would say as well, because then you would know what it takes to be a mentor and what it takes to be a mentee. So do it both ways. Connect at personal level, not just superficially. That way you're gonna make like lifelong friends. Carve your own path. So while people may inspire you, you do your own way. Do not copy other people. Ready to be surprised. You make plans, life happens, so be flexible. And at the very same time, do not sacrifice your personal life. I know that medicine is super competitive, is hyper competitive, but do not sacrifice personal life. And the last, be the birds in the sky. You can compete while being in the sky, but it's hard to compete while being on the road. If you're on the road and competing, you're gonna either kill other person or get blocked by other person. But if you're on the sky, there is like open sky, so it's easier to move around. And that's the end. Just different images of pathology that I wanted to highlight. So it's beautiful. It's kind of lit as well. We use direct immunofluorescence, that image. That just highlighting under fluorescence microscopy shows the antigen antibody reaction, and based on that we can diagnose certain diseases as well. So that's all from me, and thanks for listening. Any questions, I'm happy to take.
Thank you very much, Dr. Ahmed. We really appreciate you taking the time to mentor us. I know that you might not be able to hear us, so we're calling you.
Well,
okay. All right, so let me put you on speakerphone so that the students can also hear you.
Sure.
All right. Hello, Dr. Ahmed. Are you able to hear me?
Yes, I can. Sorry.
Yeah, that's something we'll have to have. But my name is Hamza. I'm a student at the BSDO program at Seton Hill University and the Lake Erie College of Osteopathic Medicine. And I'll be doing the Q&A. I'll begin the Q&A. So to start off, the first question we have is, when shadowing physicians, we sometimes hear them order labs just CBC with differential. What does the differential mean, and what type of smear examination is used?
Right. So the blood smear I showed you, that normal peripheral smear, so that is just like you take a drop of blood and smear it on the glass slide. So that's actual examination of the slide by a pathologist. But now we also have automated machines that can actually count the cells on those slides. And that's what CBC does. So it just counts different types of cells. So you have red blood cells, you have platelets, you have white blood cells. And then white blood cells are further divided into like neutrophils, lymphocytes, monocytes, different kind of white blood cells. So those CBC gives you those counts. So CBC actually gives you the main count of red blood cells, platelets, and white blood cells. And the differential count gives you the white blood cell counts. CBC also gives you the size of red blood cells and hemoglobin in red blood cells, platelet volume, and all those. And most of those are measured automatically.
All right, thank you for the answer. The second question we have is, we've learned from previous shadowing sessions that some physicians in the US are limited to the number of laboratory tests that they can order from patients for insurance purposes. How can pathologists in the US work towards making healthcare more accessible to patients?
So the problem is, I think I would say the insurance companies. The healthcare in the United States is very much driven by insurance companies, and we are the ones that are actually sitting behind the scenes. We are not seeing the patient. Patients don't see us. So it's highly dependent on clinicians. There has been movement in pathology to have patients like call us, discuss their results with us. So that's going to give them a little bit of services that we can offer them for which they are being charged, which they don't even know about. So I think informing our patients that we exist, I think that's the number one step, and we are working on it. It's slow, and it's not working because even if we do have consultations with patients, we are not going to be paid for that, right? If we charge the patient for our services, for all the lab testing done, but we do not charge the patient for our consultation. So those are two major issues, I would say.
All right, thank you for that answer. How has the interest in pursuing pathology professions increased over the years?
Sorry, I didn't catch you.
So the question was, how has the interest in pursuing pathology as a profession increased over the past few years? It's dependent on the institution, and it depends on where you are. I think many medical schools are struggling with recruiting pathologists from medical school because there is no mandatory pathology rotation in medical school. So many medical students don't get exposed to pathology in their career. They graduate from medical school and they still don't know what pathology is and what happens in pathology. So it has been stable, especially for American graduates. I would say it has been stable, if not a decrease in past years. We do see an increase in foreign medical graduates, but we are trying to change. Many national organizations are trying to help pathology interest group and medical students and bring first year and second year medical students into pathology lab and show them what we do. In Chicago area, where I was trained at Loyola, we had a very strong pathology interest group, and we were having almost 3 to 4 medical students every year from that class coming into pathology, which was a big achievement. Having 3 or 4 students in a school in a class, it's a big achievement. So it varies and depends on the medical school where you are. Thank you for the answer. The next question we have is, what is your work-life balance like, and how are you teaching your days split with your clinical days in the lab?
Mm-hmm. So I consider pathology as a specialty, and we don't have as many calls. We don't have to work on weekends for the most part. And with automation and digital pathology, you can, even if there are calls, you can do it from home. So I think that's the benefit. It also depends on your subspecialty and the place where you are working. So in academics, you do get some time off service. Some weeks you are on service, and some weeks you are off service. And during those off service time, you teach, you research, so all that stuff. So I think it provides a great balance in terms of work-life balance and satisfaction. And I showed you guys that survey that most of the pathologists are very satisfied with their profession. Usually you work 40 to 50 hours a week, I would say.
Okay, thank you for that answer. Here's another question we have. Can you tell us more about flow cytometry, and if that is something pathologists perform on their own?
Right. So what flow cytometry is that we take blood or any fluid or lymph node. So it's related to hematology. and then we label them with different stains, different antigens, and then a single cell is passed through a flow cytometer. And then that flow cytometer analyzes each of that cell based on their cell size, based on the granules in the cell, and based on the antigens it has on that. And then we get an analyzed result on it that this cell is of this size, this cell has this many granules, and this cell has this many antigens. And based on that, we determine what kind of cell is that. So we know that many like immature cells or blast cells or abnormal cells, they have certain antigens. So based on those antigens, we can determine if this is an immature cell or the neoplastic cells, mostly used in hematology. So pathologists do not run the test, but they analyze the test. So once we have the report, we make the diagnosis out of that. So we get these different graphs of those different cells, size, antigens, and all that. And then based on that, we make the diagnosis on what's happening there. But it's usually medical laboratory scientists who run the test.
Hey, thank you for that answer. This next question comes from Chinwendu Alonso. How do you fall into pathology? Did you also want to do pathology, or were you steered towards it?
So I did a research fellowship after my med school, and that was in like graduate medical education. And during that time, I wanted to do some clinical research as well. And then I was working with this gastroenterologist who pulled me into a project that was kind of related to pathology as well. And then that was the first time I met with like a cytopathologist. And he was very inspiring, and he included me in a few researches. I shadowed him. And I just love the work. I like the actual evidence of the disease. Like we always hear that you have this disease, but what's the evidence? So that objective evidence part of it really inspired me to explore the field, and I really loved it. So I was not steered into it. That was my own choice.
And thank you. The last question I'm going to ask before I give this off to Faizan is, what are the challenges between interpreting digital slides images and glass slides? And will digital slide images affect the need for unstained slides during outside consultations?
Okay. So the challenges between interpreting digital slide images and glass slide is it's like breaking your habit, I would say. You're so much used to evaluate on glass slides. Sometimes it makes it difficult to like maneuver it on the screen. And it also depends on the system you're using. So it has to be really fast system. Your internet has to be really good. So all those things play a part when you're analyzing it on digital slide. We are not using digital slides for diagnosis as of yet in the mainstream pathologist practice. We are still using glass slides, but there are a few practices that are using it. They like it, and it's coming up. But the main challenge, I think, the cost and labor. The scanners are really expensive, and the speed is slow. And if somebody can be more productive with glass slides, I think they are allowed to do that. So it depends on how fast you are on either way. And the second part is the need for unstained. So you still have to stain the slide because you cannot see the tissue on an unstained slides. But so if you are having a consult case from somewhere else, you can ask them to scan the stained slide, and sometimes we request those unstained slides to perform immunohistochemical stains. So I don't think it's going to completely eliminate the need for unstained slides during outside consultation, unless the referring institution performs the stain by themselves and then scan it, and then we see that. So I don't think that's going to completely eliminate the need.
All right, thank you very much, Dr. Ahmed. I'll be passing off the last parts of the Q&A to Faizan.
Okay.
Hi, Dr. Ahmed. This is Faizan. I'm a high school student from the state of Illinois, same state as you work in. So I'll start the rest of the Q&A session with a question from Rayan Kadir. He's asking, have you done any research in pathology?
Yes, so when I was doing my research fellowship, that's when I was involved in clinical research. At that time, most of the topics that I explored were cytopathology, but during my residency, I was geared more towards derm path, so was more related to skin path and heme path. And besides that, my research also entailed like medical education and like social media in terms of education in pathology. So those are kind of my interests.
Thank you for your answer. Our next question is that personally, one thing that we're told in school is that pathologists and radiologists have limited interaction with patients, as you mentioned before. And if we were to prefer working without them to become a pathologist. So how much time do you spend with patients, and do you spend more time analyzing and diagnosing patient tissue in the lab? I think this was already answered, so.
Yeah, so I think the patient interaction you can have in fields like cytopathology or transfusion medicine. So those are the two subspecialties in pathology that you still see patient. Transfusion medicine, it's pretty much you are their clinician when they come for transfusion. In cytopathology, you are sampling the patients whenever there's a superficial lesion. So you are the one who is actually taking the sample from the patient. So those are two subspecialties that we are dealing with patients day to day. Derm path and heme path, there's a lot of clinical information required to make the diagnosis. In derm path, when you're doing your fellowship, half of your fellowship is actually seeing the patients. But when you are done, you don't see patients. So yes, the patient interaction is minimal, but there are opportunities for patient interaction if you want to.
Mm-hmm. And our next question is, how have Henrietta Lacks cells contributed to advancing the field of pathology? And do you use these cells to diagnose a specific metastatic cancers?
No, we do not use those. And that's kind of like a dark chapter in medicine. So, I mean, it advanced the field, it advanced this medicine in general, but we don't use those. Those are mostly used in like research labs. And if you are interested and somebody's interested in conducting bench research or lab research, those are not the only type of cells that are being used. There are like hundreds and hundreds of types of cells that are being used. I don't think, and especially with pathologists who are doing like clinical day-to-day clinical practice, they don't deal with the research stuff.
Mm-hmm. And our next question came from, in some cases, how might hematoxylin and eosin compounds like help identify cell compound abnormalities like from the start? So like, I think this was
to stay in every case with hematoxylin and eosin. Without that, there is no pathology.
Okay, and for our last question, how do pathologists obtain specimens from patients in a telemedicine setting?
In what setting?
In a telemedicine setting. So like doctor and patient communicate like via technology.
Yes, I mean, they would have to go to certain places to get their samples received, but otherwise there's no way. So even if, like, for example, if you are doing telemedicine, you still have to go somewhere for your radiology. So similarly, to take samples, you have to go to some place to get your samples taken.
Mm-hmm. Thank you, Dr. Ahmed. That is all the questions we have today. Now I'll hand it off to the rest of the members to end off their TeleShadowing session.
Somebody's asking about, I guess, some journal that would be good for students to start looking at and reading. So the video I showed, the Pathologist magazine, I think that would be a good journal or good magazine to start with, the Pathologist.
Thank you so much, Dr. Ahmed. I know that or you're still able to hear me now. We really appreciate it. We really truly appreciate you taking all the time to answer all of our questions and taking the time out of your day to mentor us. I love everyone to please give a warm thank you to Dr. Ahmed in the chat box for this incredibly informative session. Thank you.
Thank you. My pleasure. All the best to all of you.
Thank you so much. And we will now conduct our closing session with our quiz and future session dates.
Okay, so the link to the quiz for the session is now live. You'll need a 70% or higher to pass and receive certification. The link to the quiz is being sent in the chat right now. And many of our students have also expressed interest in pursuing a leadership position in teleshadowing. So we've reopened our leadership application for students interested in joining our team as well. And for our next session dates, these dates will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. And our next session will be next Saturday on February 12th at 10 a.m. Eastern Standard Time. Also, as we reach our one-year anniversary in mid-February, we'd like to announce that our first ever physician mentor, Dr. John Green, would be joining us again on Friday, February 18th, for another session along with a medical school panel. Thank you so much, everyone, for attending today's session, and we hope to see you in the upcoming sessions as well. This concludes this week's shadowing.